Surgeons have a name for what happens to the brain after certain operations. They call it the silent complication, not the infection, not the blood clot, not the wound that refuses to heal, the anesthesia itself. And if you are over 70, or if someone you love is scheduled for surgery in the coming months, this video might be the most important thing you watch before anyone steps into that operating room. Because there is a question almost nobody thinks to ask. A question your surgical team may never volunteer. And by the end of this video, you will know exactly what that question is, how to ask it, and what 4 specific alternatives exist that could protect the most important organ in your body, your brain. Stay with me. This matters more than most people realize. Most people, when they find out they need surgery, focus on one thing: the surgeon, the technique, the success rate of the procedure itself. They ask, is this doctor experienced? They search, recovery time after hip replacement. They worry about the incision, the anesthesia wearing off, the pain in the first few days after the operation, and all of that makes sense. Those are reasonable concerns, and I understand them completely. I am not dismissing any of it, but here is what I have watched happen, year after year, decade after decade, working as an anesthesiologist. And this shift in focus changes everything. The surgery itself is often not the greatest risk for a patient over 70. The type of anesthesia is, specifically, general anesthesia. The kind that puts you fully under, where you are not just asleep, but your brain is chemically suppressed to a deep level. A tube is placed down your throat, and a machine takes over the act of breathing for you. For a healthy 40-year-old, the brain recovers. The body rebounds. A week later, they feel like themselves again. But for someone over 70, that pharmacological shutdown of the brain can trigger something that stays with you long after the stitches are gone. So the question is no longer just, who is doing my surgery? The real question is this: how is my brain being protected during it? Most patients never think to ask that. And most surgical teams never bring it up unless a patient specifically raises the issue. Let me show you exactly why this matters biologically. Because once you understand the mechanism, you cannot unhear it. The brain of a 70-year-old is not the same as the brain of a 40-year-old. I want to be precise here, because this is not about declining intelligence or weakness. It is about something called cognitive reserve. Cognitive reserve is the brain's buffer, its tolerance for disruption, its ability to absorb a pharmacological shock and return to baseline cleanly afterward. Younger brains have substantial reserve. Older brains have less. The margin for error is genuinely narrower. When we administer general anesthesia, we deliver a combination of induction agents, muscle relaxants, and volatile anesthetic gases. These drugs bind to receptors throughout the entire central nervous system. They do not gently sedate you. They suppress the brain systematically, including the regions responsible for memory consolidation, spatial orientation, and sustained attention. And in a patient over 70, the liver and kidneys clear these drugs more slowly than in a younger patient, sometimes significantly more slowly. The drugs linger in the system longer. The receptor exposure is prolonged beyond what the dosing schedule technically accounts for. The neurological recovery window stretches out in ways that are not always predictable. What happens next? In roughly 30 to 40% of patients over 70, something appears in the first 1 to 3 days after surgery. Postoperative delirium. That is not a minor side effect. I want you to understand what delirium actually looks like in a real human being, because the word sounds clinical and distant, and the reality is anything but. The patient wakes up, and they do not know where they are. They believe they are at home, or in a place from 30 years ago. They become agitated, or they go completely still and unreachable. Sometimes they see things that are not present in the room. Sometimes they do not recognize family members who are standing right beside them, reaching for their hand. One daughter described it to me this way, after her father's knee surgery. He looked at me like I was a stranger. He knew my name when I said it, but his eyes were somewhere else entirely. Like the person I knew was behind a frosted window. The family had been waiting in the corridor, expecting their loved one to be groggy but oriented, a little disoriented perhaps, but essentially himself. What they found instead was genuinely frightening. And here's what I need you to understand about delirium, because this is the domino effect that most patients are never warned about before they sign a consent form. Delirium is not always temporary. In a significant number of elderly patients, Delirium is followed by something called postoperative cognitive dysfunction. Clinically, we abbreviate it as POCD. The memory does not fully come back. Processing speed stays sluggish. The sharpness that was there before surgery, that clarity, that quickness, the ability to track several things at once, to recall names without struggling, to follow a conversation without losing the thread, it is diminished, sometimes for weeks, sometimes for months. In some patients, the evidence suggests the decline does not fully reverse. And consider what this means practically. This is a person who is driving independently before the operation, managing their own finances, cooking for themselves, living fully. And now a family member is quietly moving in to help, or conversations are happening behind closed doors about assisted living, and the surgery that was meant to improve their quality of life has instead become the marker in time when everything changed. This is not theoretical. The data has been accumulating since the 1990s. Postoperative cognitive dysfunction in elderly patients is one of the most actively researched areas in anesthesiology right now, precisely because the aging population is growing rapidly and the stakes are rising year by year. Now let me be precise, because I want to be accurate and fair. Researchers are still actively debating whether general anesthesia directly causes lasting cognitive decline, or whether it accelerates a neurological process that was already beginning very gradually. The science is ongoing, and honest practitioners acknowledge the uncertainty. But here is what I can tell you from 30 years of clinical practice. We consistently see better cognitive outcomes in elderly patients who receive regional anesthesia rather than general anesthesia. The difference is not marginal. It is clinically meaningful. It shows up in delirium rates, in length of hospital stay, in how quickly patients return to independent function, and in family reports of cognitive baseline after discharge. That pattern is consistent enough that many leading surgical centers, in the United Kingdom, across Scandinavia, in major academic medical centers throughout North America, have now made regional techniques their default approach for elderly patients, wherever it is medically feasible. Which raises the obvious question: why is this still not standard everywhere? Why are so many patients over 70 still receiving general anesthesia when alternatives exist? This is where most elderly patients hit a wall. And it is the central domino I want to knock over for you today. They do their research. They become concerned. They arrive at the preoperative consultation and say something like, "I read about cognitive risk with anesthesia. Is there another option for my surgery?" And sometimes, not always, but often enough to be a real pattern, they hear this: "This is standard procedure for this operation." Or, "Don't worry, you will be completely safe." Or simply, "We do this with everyone." And the patient backs down. Because who are they to push back against the surgeon? But here's the problem with standard procedure. Standard protocol was designed for the average patient population. The average patient population, weighted across all ages, skews significantly younger. When you are over 70, you are not in the average patient population for anesthetic risk. You are in a different physiological category, with different drug metabolism rates, different cerebrovascular reserve, different receptive sensitivity, and different cognitive vulnerability. Your anesthetic plan should reflect that individual reality. I am not saying general anesthesia is always avoidable. There are procedures where it is genuinely necessary. Complex cardiac surgery, certain neurosurgical procedures, long abdominal operations with specific airway or positioning requirements, emergency situations where time does not allow for a careful regional setup. When general anesthesia is truly necessary, a skilled anesthesiologist will do everything possible to protect the aging brain. Careful drug selection, minimizing total doses, using brain activity monitoring when appropriate, ensuring the fastest possible emergence from anesthesia, and carefully managing sedation during the recovery period to prevent oversuppression. But the reality is that general anesthesia is far more avoidable than most elderly patients are ever told, because there are 4 specific regional techniques, each matched to a different type of surgery, that allow a patient to undergo a major procedure without deep brain suppression. And I'm going to give you all 4 right now, with the detail you need to have a genuinely informed conversation. The first, and I want to start here because it is arguably the most transformative technique for surgery involving the limbs, is peripheral nerve block. Let me explain what this actually is, because the name sounds technical, but the concept is elegant in its simplicity. Pain signals from any surgical site travel through specific named nerve pathways before they ever reach the brain. The shoulder, the knee, the hip, the hand, the foot. Each region is served by identifiable, precisely mappable nerve bundles that follow predictable anatomical routes. What if we intercept those signals before they travel? That is exactly what peripheral nerve block does. Using real-time ultrasound imaging, technology that allows us to visualize the precise location of the target nerve on a screen in front of us, we place a small amount of local anesthetic adjacent to that nerve bundle. The result is complete numbness of the entire surgical region, not the whole body, not the whole spinal cord, precisely and only the operative site. The patient is awake throughout, or resting in very light, comfortable sedation, a gentle drowsiness, nothing like unconsciousness. The brain is not suppressed. There is no tube in the throat, no ventilator, no systemic pharmacological shutdown. The patient breathes on their own, maintains their own airway, and can respond and speak if needed. And the block continues working for 12 to 24 hours after surgery ends. That critical first day of recovery, which is typically the most painful, is already covered by the local anesthetic that was placed before the first incision. The patient requires dramatically less opioid pain medication afterward, and opioids in elderly patients carry their own significant cognitive risks: confusion, excessive sedation, balance problems, and falls. Avoiding large doses of them is a meaningful benefit on multiple levels. For hip replacements, knee replacements, shoulder repairs, and hand surgeries, peripheral nerve block is genuinely changing how we approach anesthesia in elderly patients. The outcomes data is substantial and continues to grow stronger with each passing year of research. The second technique is epidural anesthesia, and this is the appropriate approach for larger operations involving the abdomen or the chest. You may have heard of epidurals in the context of childbirth, but epidural anesthesia for major surgery in elderly patients is equally powerful, and for procedures like bowel resection, aortic surgery, or certain thoracic operations, it can be the single most significant cognitive protective factor available to the patient. A thin catheter, a very fine, flexible tube, roughly the diameter of a strand of thick thread, is placed in the epidural space. That is the space just outside the membrane surrounding the spinal cord, in the middle of the back. Through this catheter, local anesthetic is delivered continuously throughout the operation, covering the entire surgical area with precision and consistency. The result is that the patient requires dramatically less general anesthetic agent. In many cases, the epidural provides sufficient pain coverage that the general anesthetic component is reduced to a minimum, just enough to ensure comfort and stillness, rather than the full pharmacological load that would otherwise be required. The brain is largely spared the deeper chemical suppression. The catheter remains in place for 2 or 3 days after surgery. Post-operative pain is managed continuously, with precision, using a fraction of the systemic drug doses that would otherwise be needed. The patient moves earlier. Respiratory complications associated with inadequate pain control are reduced. The entire recovery trajectory is fundamentally different and measurably better. The third technique is spinal anesthesia, which is distinct from epidural and is the preferred method for surgery of the lower body. Hip fractures, knee procedures, bladder and prostate operations, lower abdominal hernia repairs. A single, carefully placed injection delivers local anesthetic into the cerebrospinal fluid in the lower lumbar spine. The anesthetic spreads upward to a precisely controlled level, creating complete numbness from roughly the waist down. The effect typically lasts 2 to 4 hours, which covers most lower body procedures comfortably. The patient can doze lightly during the operation, or listen to music, or simply rest quietly. Some request mild sedation for comfort, but the brain is not chemically suppressed to the level of general anesthesia. The airway is maintained entirely by the patient themselves. No tube, no ventilator, no forced pharmacological shutdown of consciousness. For elderly patients with hip fractures in particular, spinal anesthesia has become the preferred standard in many leading centers worldwide. The data on delirium reduction compared to general anesthesia is consistent across different patient populations, different countries, and different healthcare systems. This is not a niche or experimental approach. It is mainstream medicine, moving in a clear and well-supported direction. The fourth technique, and this one surprises many patients because they had never considered it an option, is conscious sedation combined with local anesthesia. This is the approach for smaller procedures. Cataract surgery, carpal tunnel release, hand and wrist operations, minor hernia repairs, certain skin procedures and biopsies. The patient receives carefully titrated sedation, producing what we call twilight state. Relaxed, calm, anxiety absent. If someone says your name, you respond. You are aware at a gentle level. You are not unconscious, not intubated, and your brain is not carrying the full pharmacological burden of general anesthesia. The local anesthetic is injected directly into the surgical site, providing complete pain control for the procedure itself. For cataract surgery specifically, a procedure that takes less than 20 minutes in experienced hands, many elderly patients are still receiving general anesthesia purely out of institutional habit and departmental routine. Conscious sedation is perfectly adequate, gentler on the aging brain, associated with faster recovery, and allows the patient to go home the same day, often feeling nearly normal within hours. The difference in cognitive experience for the patient is significant. Now, let me give you the precise language to use at your preoperative consultation, because knowing the 4 techniques is only half of it. The other half is knowing how to open the conversation without being dismissed or reassured away from pursuing it. When you sit down with your surgical team before the operation, say this: I have read about the cognitive risks of general anesthesia for patients over 70. Can we discuss whether a regional approach is appropriate for my specific procedure to reduce the risk of postoperative delirium and cognitive dysfunction? That question does 2 things at once. It signals that you are informed and specific, not vague, not anxious, but knowledgeable about the clinical literature. And it opens a genuine clinical conversation rather than a reflexive reassurance. If the answer is that general anesthesia is truly necessary, ask why. What specific aspect of this surgery requires general anesthesia that a regional technique cannot address? That is a fair, specific clinical question. It deserves a fair, specific clinical answer. If what you receive instead is, this is just what we do routinely, without further clinical reasoning, that is the moment to request a separate consultation with the anesthesiologist directly. The anesthetic plan is substantially within the anesthesiologist's decision-making authority. A good anesthesiologist who works regularly with elderly patients will often welcome exactly this conversation. They think carefully about these risks. They want to protect you. They may simply need to know that you want to have the discussion, because many patients never raise it, and teams default to what they always do. I want you to picture 2 patients. Both real patterns I have witnessed many times across many years of practice. Patient 1, a 78-year-old man, sharp, independent, drives himself to appointments, manages his own finances without help, does the crossword every morning and rarely leaves it unfinished. He has a knee replacement under standard general anesthesia. The surgical result is technically excellent. The knee functions well by the 6-week mark. 3 weeks after surgery, his daughter calls. He got lost driving to the pharmacy he has used every month for 12 years. He forgot a detailed family conversation that happened the day before. A conversation about something that mattered deeply to him. His crossword puzzles are sitting on the table. Started but abandoned. The pen is capped beside them. He is not the same person who walked into that operating room. The knee healed, but something else did not fully come back. Patient 2, an 81-year-old woman with a hip fracture after a fall. We perform the repair under spinal anesthesia with light sedation. During the procedure, she talks with her daughter on the other side of the surgical drape. She asks about the grandchildren. She makes a joke about the paper cap they made her wear. The procedure takes under 90 minutes. By day 2, she is walking with the physiotherapist. By day 4, she is home. 1 week later, she telephones the office to say thank you. She wanted us to know she is back in her garden. Her mind is completely clear. I have watched both of these stories play out, in different forms, more times than I can count. And the difference between them often comes down to a single conversation that either happened or did not happen before the operation began. The surgery protects the body. The right anesthesia protects the mind. And at 70, at 75, at 80, your mind is worth fighting for. Before your next surgery, or before anyone you love goes in for a procedure, write these 4 options down and bring that piece of paper to the consultation. Peripheral nerve block for operations on the limbs and joints. Epidural anesthesia for major chest or abdominal surgery. Spinal anesthesia for procedures below the waist. Conscious sedation with local anesthesia for smaller operations. Write the question down too. Can we discuss whether a regional approach is appropriate for my procedure to reduce the risk of postoperative cognitive complications? Ask it. Have the conversation before you are in the operating room, not after you are recovering in it, because informed patients receive better, more individualized care. Not because the system is adversarial, but because a patient who asks specific, knowledgeable questions prompts a specific, considered response. It genuinely changes the dynamic in the room. It invites your team to think carefully about your individual situation, rather than defaulting to the standard protocol designed for the average patient across all ages. Every patient is different. Every procedure is different. If you have existing cardiac conditions, if you are on anticoagulants, if there are specific anatomical considerations, all of that factors into the decision, and your doctors know your individual situation in ways I cannot from a screen. What I'm giving you today is the framework for a better, more informed conversation. The starting point, not the final word. If this was useful, share it with someone who has surgery coming up, or with a family member who cares for an elderly parent. It takes 30 seconds to send, and it might genuinely change the conversation they have with their doctor. And if you want to understand what happens to the aging brain during the full course of hospitalization, not just during surgery, but throughout the recovery process, and why those first 72 hours after the procedure are so critical for long-term cognitive outcomes, I covered that in detail in another video. The link is in the description below. Take care of yourself, and take care of your mind.